Now, yesterday what I talked about is the antidepressant literature. I'm not going to go over the data again, but what you find when you try to see when you flesh out how antidepressants affect people's lives over the long term, you find this. Prior to the use of antidepressants, the research showed that depression, by and large, was an episodic disorder. With time, people would recover from an episode. They would recover to what is known as euthymia, an absence of symptoms. And then if we follow those people for 15 years, we'd sort of see a spectrum of outcomes like this. About half of people would never become depressed again, or at least not seriously enough to be rehospitalized, and these are studies in hospitalized patients. About 30% would seem to have an episode every 3 years, 2, 3, 4 years. And so over the course of 15 years, they might have 3 or 4 episodes. And it was that group that also showed, well, listen, this is an episodic thing. It does come back in a number of people. And then maybe 15 to 20% would become chronically depressed. But remember, this is in a group of patients that are hospitalized for depression. These are severely depressed patients we're following long term. Then what you find real quickly is once the drugs are introduced, people notice something odd. I'm talking about doctors. Doctors who've been treating depressed patients before the antidepressants came. Now they get a new tool. And now they're seeing a different course in their patients. And what do they see? Boy, my patients are getting better faster, but boy, are they relapsing back into depression more frequently than before. So right away in the clinical perceptions, you see a worry about maybe we're causing a chronification of the disease. Now you look at the course of depression today, it does run a much more chronic course. That's acknowledged. I'm talking about medicated depression. If you compare studies, if you find studies that go from 5, 10 years, and also look at functional outcomes. Are people working or not? And are they symptomatic? I will tell you, every time the unmedicated patients do better over the long term. They have less depressive symptoms over the long term, and they have higher functional rates, less disability rates. So what you see in that, and then, this is the kicker to this story, as this has become more and more, at least some people acknowledging this chronic course, that we're seeing in medicated depressed patients today, there's at least a few researchers saying, what's going on? And here's what they're saying. Just a few willing to go down this. These drugs, over the long term, induce the opposite effect of what they do over the short term. Because it's supposed to up serotonergic activity, it actually drives your brain into a lower serotonergic state. And maybe that's why we get these chronic conditions, because over the long term, they're causing these compensatory changes in the brain, the opposite of what the drug is supposed to do, and that's the problem. Okay? That's the story for antidepressants, and basically that's the story I could tell you for every class of drugs. I was going to do antipsychotics today, and one of the reasons, I know you're not so interested in antipsychotics, but one of the reasons doing antipsychotics is good is because in this narrative of progress, antipsychotics sit at the heart of this narrative of progress. They're the drugs that came in, made it possible for these crazy, mad, chronic patients in the asylums to come out, live fairly normal lives. In our society, generally it's considered heresy to say that anybody with psychosis or diagnosis of schizophrenia could do okay off the medications. We have laws now increasingly that force people with certain diagnoses to take antipsychotics in the community. So if there's any class of drugs that should have a clear long-term benefit story in science, it's the antipsychotics. And real quickly, and then we'll sort of put this one to rest, you see the same paradox emerge in the scientific literature around antipsychotics. So what do you see? You do see some short-term effectiveness in terms of knocking down psychotic symptoms over the short term. That's there. That's why they get approved. But then if we go back to their introduction and we look at clinicians as these drugs are introduced, they say this. You know, boy, these patients are coming back like crazy. And they even invent, back to the hospitals. So they get treated with drugs. They go out. Often they do throw the drugs away. And they say, boy, they're coming back to the hospital more frequently than before. It's like a revolving door syndrome. They even use this language. And then they say this, you know, it also seems like now when people relapse after being exposed to drugs, their psychotic symptoms are more severe than we used to see in placebo patients. And especially they'd say if people are on the drug, they stop the drug, we get really severe relapses. And real quickly, do you know how antipsychotics work? What they do now is they block dopamine receptors in the brain. It's like they're glue in that lock, so they thwart dopamine transmission. So what does your brain do? It ups its dopaminergic transmission. For a period of time, the presynaptic neurons put out more dopamine than normal, and then your receiving neurons will increase their density of dopamine neurons from anywhere from 30 to 100%. Okay? So now you become super sensitive to dopamine. Then there's 4 studies in the 70s funded by the NIMH that are meant to revisit the effect of antipsychotics on the long-term course of schizophrenia. Here's what they find, real quickly. They do a retrospective study. They look at outcomes, 5-year outcomes from a group of patients treated in 1947 at Boston Psychopathic Hospital with psychosocial care, no drugs. They compare outcomes of a group of patients treated in 1967 with psychosocial care plus drugs. And what do they find? Higher relapse rates, in other words, rehospitalization rates in the modern group, and much more important is much less adequate social functioning. They're much less likely to be employed, much less likely to be engaged with other human beings, in other words, marrying, having kids. And so what does this Samuel Bachhoven says? If we're interested in long-term clinical improvement and functional improvement, we have to rethink these drugs. Then there's 3 studies funded by the NIMH during the 1970s, and basically they go like this. We're going to have one group that gets conventional care with drugs, hospital, and then we're going to have an experimental arm. And in this experimental arm, we're going to give them psychotherapy, psychosocial care, milieu therapy, and we're going to use drugs in this way, either not at all, or we're going to use them in a selective manner. If people aren't getting better after 6 weeks, we'll try to use low doses. So it's more of a selective use model. Each time, the outcomes were better for the experimental arm. So you'd see over the long term lower relapse rates and higher function. And each time you see the researchers go, if we're interested in long-term outcomes and not just short-term symptom suppression, we have to rethink this. And then in 1979, William Carpenter, who still today is a leading schizophrenia researcher, raises a really profound question. Now think about the data he has. He actually has 3 parts of data. He has the short-term data that shows you knock down symptoms better with drug than on placebo. Then they did studies designed like this. And these are the studies that are cited to justify long-term use of antipsychotics. You take people who stabilized well on antipsychotics, which isn't everybody, that's a good responder subset, and you would do studies where you abruptly withdrew the drug, half the patients, randomized studies. The other half you would keep on the drug, and with great regularity, those withdrawn relapsed at high rates. And so what doctors said at the time, see, you take the drug away and the disease returns. Now we know today a lot of what we're seeing in that relapse rate is in fact a withdrawal effect. But it's perceived at the time as you take the drug away, the disease returns. So he has that bit of data, William Carpenter. He's at the National Institute of Mental Health, but now he has also this data showing it seems like relapse rates, in fact, are higher in drug-exposed groups. So what does he say? And watch this, listen to this. We know that once patients are on antipsychotics, they are less vulnerable to relapse if maintained on the drugs. That's the withdrawal studies. But he says, but we raise this possibility. What would happen if these people had never been exposed to antipsychotics and never undergone this change? We raise the possibility that these drugs are making people more biologically vulnerable to psychosis than they would be in the normal course of their illness. So you see here, here's where the alarm flag goes up, right? Because this is the target symptom. This is not a side effect. They're saying these drugs may be making people more psychotic than they would be normally. At that point, 2 researchers from McGill University, Barry Jones and Gil Chenard, say, we know what's happening. These drugs induce these changes in the brain that make the brain super sensitive to dopamine. Got all these extra dopamine receptors, and that's why when you come off, you're getting such severe symptoms. He says, but even if you remain on, you may get something called tardive psychosis, where because of impairment in that dopaminergic system, the people are going to become chronically psychotic. And he does a study, and he figures out that tardive psychosis seems to develop about 3% per year. After 1 year, 3% of people on the antipsychotics have permanent psychosis. After 10 years, it looks like 30% and keeps going. So what the image that comes out is these drugs actually increase psychosis over the long term. And stop even thinking about all the side effects. There's all side effects. This is on the target symptom. Anyway, if you go forward, then the question is, that happens in the 1980s. Do we have reason to believe that this is so? We do get new drugs, or not so? Is that a false alarm or not? And here's what I'll tell you the data is. And I'll go through this real quickly. The World Health Organization, and the data comes from all different data points, okay? And my job as a reporter is just to find whatever data I can find that in some way has a bearing on this. And I wouldn't say that any one study is definitive. The question is, does the puzzle fit together? So we have a World Health Organization study that compared outcomes in 3 developing countries, India, Colombia, and Nigeria, with outcomes in the US and another 6 other rich countries. First one was 5 years in length, and the researchers found something odd. Outcomes were much better in the poor countries, particularly India and Nigeria. And they said, what's going on? And they said, particularly what's amazing is they concluded this after the first study. Living in a developed country is, quote, a strong predictor that you won't have a good outcome if you're diagnosed with schizophrenia. And this was actually the finding that got me interested in this whole field, because I'm like, why would living in a rich country with all our great medicine be a predictor you won't do well long-term with this disorder? So they hypothesized at this time that maybe the problem or maybe the reason for the better outcomes in the poor countries is the patients there are more medication compliant. They take their antipsychotics regularly. Now that's a valid hypothesis. If you think that medications are so essential, greater medication compliance should be associated with better outcomes. What'd they find? They found in the countries with the 2 best outcomes, India and Nigeria, they used the drugs very differently. Acutely, not chronically. So they would use them to get them through that psychotic episode, then they would take them off. And in those countries, in those 2 countries, only about 10% of patients were maintained on drugs long term. So in those studies, what do you see? Better long-term outcomes where they're using the drugs differently.